Good evening and welcome to the third and final session of the Humanitarian Congress Tokyo 2021. I am Dr. Clara Van Gulik, a pediatrician and medical advisor for Médecins Sans Frontières and writer for MSF Medical Guidelines in Newborn and Pediatric Care. I have the honor this evening of moderating this session with a lineup of inspiring speakers presenting to us from Japan, Belgium, and Pakistan. In the past 15 years that I've been working with MSF, both in the field and at headquarters as a child health and HIV/TB specialist, the progress I have seen in global health indicators and in the care we can give to patients in the most remote or unstable settings has been really impressive and encouraging. The risk of a massive setback to all that progress as a side effect of measures taken due to the pandemic is really worrying. The reality we face is that this pandemic has and is still directly claiming many lives, and even as I speak to you now today, hundreds and thousands remain in critical condition in intensive care wards around the world. But at the same time, as you are all aware, and I'm sure being affected yourselves too, beyond COVID-19 infection, the secondary impact of the pandemic have raised alarm bells around the globe. From suspension of or reduced medical services, closed clinics, overwhelmed hospitals, travel and movement restrictions, lockdowns, school and university closures, job losses, we are seeing significant social and economic damages that then impact people's health. As we shifted from Millennium Development Goals to the SDGs, the Sustainable Development Goals, decades of hard work to improve women and children's health was evident. In 2019, the number of deaths amongst children under the age of 5 years dropped to its lowest ever worldwide. And maternal access to safe delivery, access to family planning, access to safer abortion care, all had improved significantly. In comparison to other high-risk groups, women of childbearing age and children have mostly been spared from severe COVID-19 disease. However, while governments and health services are struggling to respond to the pandemic and all its consequences, both women and children's advocates are warning us of a potential catastrophe to come if we do not act now, so that hard-won progress in improving women and children's health is not in vain. A study from Johns Hopkins Bloomberg School of Public Health from last year looked at 118 low and middle income countries and estimated that an additional 2 million children under the age of 5 could die in just 12 months due to the measures in response to the pandemic. The increased threat to women's health, safety, well-being are multifold. Women are further cut off from vital sexual and reproductive health services, threatening sharp rises in maternal and neonatal mortality. Contraception and safe abortion care are being deprioritized as non-essential services. Lockdowns have been associated with a sharp rise in reports of domestic violence against women and girls, including sexual violence. It is crucial now more than ever to reinstate access and delivery of essential and life-saving health services and protection for women and children, and avoid the expected waves of increased preventable suffering and death for years to come. So to do that, we need to understand the challenges women and children have faced in the past year and a half, and what those challenges imply, and what needs to be done urgently. So I am very pleased to present our three speakers and invite them to share their insight, their experiences, and their recommendations so that we can understand and act on this now. So I'd like to introduce the first speaker, Ms. Mayumi Katsube Mayumi-san. She is the Executive Director of JOISEF, the Japanese Organization for International Cooperation in Family Planning, established in 1968 in Japan and currently an international NGO that is active in the field of sexual and reproductive health and rights in over 36 countries worldwide. Following a career in international cooperation with UNDP and then the Japanese Red Cross, Ms. Katsube joined JOISEF in 1991, engaging in reproductive health projects in Ghana, the Gambia, Tanzania, Nepal, the Philippines, and Vietnam. She became JOISEF's Executive Director in 2015 and concurrently Board of Directors in 2017. Ms. Katsube will share a global overview of the multitude of challenges faced by women and girls as a result of this pandemic. Our second speaker is Dr. Oluwakemi Ogundipe, to me known as Dr. Kemi, and she is a US qualified pediatrician with a specialization in global health and pediatric HIV and TB. She has a master's in public health majoring in maternal and child health. As pediatric advisor for MSF's headquarters based in Belgium, since 2018, she has been overseeing newborn and pediatric care programs globally. Prior to that, Dr. Ogundipe worked extensively in MSF field projects in many countries around the world. In the wake of the COVID-19 pandemic, she has been leading the coordination and revision of clinical and operational guidance on the management of COVID-19 in children for our MSF field programs. She also provides ongoing guidance to ensure the vital continuity of existing child health activities despite the challenges of the pandemic. And today will share with us the challenges encountered by patients and families due to the measures of the pandemic. And our third speaker is the voice from the doctor on the front line, Dr. Sobia Azim. Dr. Azim is a gynecologist from Pakistan and currently the medical activity manager at Peshawar Women's Hospital in Pakistan. After completing her governmental medical officer training in 2009, Dr. Azim specialized in obstetrics and gynecology and worked in several medical institutes in Peshawar and Nowshera, and as a district specialist in obstetrics and gynecology for the Ministry of Health in the province of Khyber Pakhtunkhwa. We have the double honor of Dr. Azim's participation today, providing us with direct insight of the challenges her and her patients face in Pakistan, but also on today, the day of the celebration of Eid, where Dr. Azim is giving her precious family time to spend some time with us. So I'd like to now move on to our first speaker, Ms. Katsube. I'd like to pass the floor to you.
Thank you very much for your introduction. ご紹介ありがとうございます。それでは、COVID-19 が女性と少女に与える影響、セクシュアル・リプロダクティブ・ヘルス・ライツ、SRHR とジェンダーの平等の危機ということでご報告いたします。発表の内容は、まず、パンデミックが宣言された直後、約1年前に、主に開発途上国で、COVID-19 が女性と少女に与えると警告されたことについて、それは何だったか振り返ってみます。そして1年後の今、何が起きているか分かっていることについて、そして、日本と先進国の状況について簡単に触れて、最後にこれから何が求められているかについて考えていきたいと思います。 警告とプロジェクションとタイトルしましたけれども、実際には、パンデミック宣言以来、女性や少女へのさまざまな影響が確認されました。世界の約90カ国でロックダウンや自宅待機、自粛や制限が敷かれたことで、影のパンデミックと呼ばれるドメスティックバイオレンスやジェンダーに基づく暴力、性的虐待や性的搾取が増えたこと、そして世界的なパンデミックの対応に多額のリソース、国際機関の支援や、国家予算が感染予防対策につぎ込まれた。そしてそのために通常の保健プログラム、特に SRHR やジェンダーの平等に関するプログラムへの支援の優先順位が下がるということが現実となっていきます。そして学校閉鎖によって子どもたちが学校に通えなくなり、同時にコロナ禍による失業や、そうした失業で家庭の中の経済状況が悪化することで、それまで学校に通えていた女の子たち、少女が学校に戻れなくなるということが懸念されました。当初、グッドマッハ研究所が132カ国の、低中所得国において、仮に SRH サービスが年間 10% 減少した場合の影響について予測を発表しました。その負の影響の大きさは大変衝撃的なものでした。例えば、中長期的なに有効な避妊サービスが 10% 減った場合、すでに世界には避妊を望んでも避妊サービスを受けられない女性が約2億人いるにもかかわらずですね、それがさらに4800万人増加すると。で、その結果、世界で年間途上国では予期しない妊娠件数が1500万件以上増えるとされました。で、また、妊産婦ケアや、新生児ケアの基本的なサービスが 10% 減少すると、妊娠合併症が170万件以上、妊産婦死亡が2万8000件、新生児合併症が259万件、また、新生児死亡が16万8000件、さらにこうした状況の中で、安全でない人工妊娠中絶が330万件増加するということでした。で、こうした予測が発表される中で、SRH サービスを提供している途上国の現場からは、次々に実際にどのような影響がパンデミックでもたらされたかという報告がなされてきました。例えば、PPE、防護具が不足して、コミュニティで SRH サービスを住民に提供するような保健スタッフや保健ボランティアの安全が確保できないという状況。そして日本でも一時、起きましたけれども、マスクなどの値段が高騰して買えなくなるというような状況も起きました。避妊具や避妊薬、性感染症の治療薬や HIV テストキット、エイズ治療薬が不足したこと、これはロックダウンの影響によって、移動が禁止され、物流が止まって現場に物資が届かない。それから感染症対策の資金がシフトしてしまい、通常の医薬品を購入する資金が不足しているなどの理由からでした。また、移動制限によって、村々にサービスを届けるようなアウトリーチができなくなって、遠隔地への保健サービスが止まってしまったなどの状況が起きました。また、例えば、国際機関の調査では、ナイジェリアにおいて、4人に1人は、必要とする保健サービスが受けられなくなった。で、うち半数以上が治療費を払えない状況であったということでした。また、ウガンダの家族学協会の報告によりますと、2019年と2020年の6月から8月の間のSRH サービスの状況を見ますと 20% 減少し、またサービス利用者も 20% 以上減少した。そして若者へのサービス、思春期の若者が必要とするサービスも 23.6% 減ってしまったという報告がされました。またネパールでは9カ所の病院の調査により、2020年1月から5月の間に施設分娩が52% 減少して死産が 50% 増加した。そして新生児死亡が2倍となったという報告がありました。そして1年経った今、 SRHR やジェンダーの平等、女性のエンパワーメント、少女のエンパワーメントの分野で活動する国連機関や国連機関の国連人口基金や UN ウーマン、そして国際家族計画連盟 IPPF、国際機関ですけれども、この事態をこのように表現しています。まず、パンデミックは広範囲にわたる影響を特に女性と女児、少女に及ぼしており、SDGs のほとんどのジェンダーの関連の目標の実現を遅らせることになるだろう。そして、このように資金が不足すると、健康の不平等、とりわけ SRHR においての不平等が立ちどころに増幅されることをこのパンデミックが突きつけたと、このように言い表しています。初期の推測、グフマハ研究所によるような初期の推測を検証するデータというのは、こうしたパンデミックの下では非常に検証が難しく、データが収集され、はっきりした数字が示されるまでには、まだ時間が必要と思われます。ですが、現時点でも女性と少女の置かれた現状が非常に深刻であることが分かっています。影のパンデミックと呼ばれる暴力やジェンダーの不平等については、国連による加盟する193の国と地域で 20% 増加したと予想されています。これは途上国も先進国も開発途上国も同様なことですね。また、開発途上国で実施された100件に上る調査報告書を分析した結果を、センター・フォー・グローバル・ディベロップメントという団体が組織が報告していますが、この分析によりますと、深刻なものから軽微なものまでの報告を含みますけれども、暴力が増加したという圧倒的なエビデンス、証拠が示されています。暴力の要因として有力なことと考えられるのは、世帯収入の減少と、それに伴う、食料が手に入らなくなるということが大きいと言われていました。また、ロックダウンが厳しければ厳しいほど、暴力も増える傾向があり、保護者、親から子どもへの暴力も深刻です。また、17カ国の低中所得国において行われた40件の調査で、死産や妊産婦死亡が3割近く増えたということがランセットの報告で分かっています。これは保健システムが緊急事態に対応しきれていない。そして、ロックダウンで社会の機能が止まり、公共交通機関が使えなくなったことや、移動そのものが禁止されてクリニックに行けなくなった、あるいはクリニックに行くことで感染を恐れる女性たちが行かないというようなこと、また、妊産婦ケアを行っていたスタッフが COVID 対応にシフトしてしまって、女性に対してサービスを行うスタッフが不足しているということなどが理由として挙げられています。また、避妊サービスが行き届かなくなったことで、当初のグッドマッハ研究所の推計よりも低い予測となっていますけれども、それでも UNFPA によりますと、1年後の現在、1200万人が避妊サービスを受けたくても受けられない。そして、その結果、予期しない妊娠が140万件増加すると言われています。さらに児童婚が増加して、これは児童婚をなくそうということで、これまで積み上げてきた努力がコロナ禍で後退してしまうというふうに恐れられています。また、女性性器切除 SGM という有害な行為が増えているという懸念が生まれています。FGM については、チャットで、UNFPA やユニセフ、NHK のニュースサイトを紹介していただいていると思うのですが、これは今、世界30カ国で行われていると言われていて、女性性器の一部、または全部を切除しているという行為でして、これなぜかということに関しては非常に複雑な状況や背景がありまして、ここではご説明できないんですけれども、こうした、大変不衛生な環境で、医療従事者ではない人たちが行うということにより、大量に出血したり、感染症で時に長女や女性の命を奪う、あるいは生涯にわたって非常に深刻な健康を害するという行為です。で、こうした、行為がですね、コロナウイルスの流行によって 今後10年間の間に、こうした FGM を受ける女性と少女がと言われています。でこれはこうした FGM 根絶のプログラムというのは学校で行われるわけですけれども、多くは、学校が休校になってプログラムの活動が行われなくなる、あるいはこのプログラム自体の資金が縮小されて、少女を守る活動が実施できないことなどが原因になっています。こうしたCOVID の影響がなければ避けられたはずのことですけれども、これはUNFPA の世界人口白書の情報ですが、ソマリアやケニアではコミュニティや難民キャンプで働くワーカーたちからこうした FGM が増えているという報告がなされたり、エチオピア、ケニア、ナイジェリア、スーダンでは少女たちを結婚させるためにこうした慣習による行為を行っているということも報告されています。で、さて、さらに忘れてはならないのは、女性が経済的に非常に困難な状況に置かれやすいということです。それはパートタイムの労働者の割合が女性に多く、このパンデミックによって仕事を失ってしまうと、そして経済的に困窮するリスクが高いということです。またさらに、これも皆さんよくご存知だと思いますが、感染症防止や治療の最前線で働く医療従事者は、70% が女性であるということ、看護師、助産師、介護者、ヘルスボランティアの方たち、途上国、先進国を問わず、女性が大半を占めているということですね。そして、ジェンダーの不平等は、こうした最前線で働く保健医療従事者に対しても顕著です。70% が75% 男性だということでした。そして、当初、こうした防護具について女性サイズがないという指摘も問題視されました。また、保健分野でも男性は女性より 28% 収入が多い。そして、世界では100万人の女性ヘルスワーカーがいて、その多くが賃金を払われていなかったり、不当に低い賃金で働いているという事実があります。そして、女性の保健医療従事者は、家事や育児を担うということも、責任というものもあるわけですね。さて、ここから簡単に、日本と先進国の状況について少し触れたいと思います。ジェンダーによって基づく暴力に関しては、先進国、途上国、区別なく増えているというふうに言われていますけれども、ここでご紹介するのはアメリカの例、8.1% ドメスティックバイオレンスが増えたという報告がありまして、また、日本の内閣府の調査ですが、昨年度、日本でもドメスティックバイオレンスの相談が 50% 増えた。そして、性暴力の相談は、昨年度の上半期には、同期間で 15.5% 増えたというふうに報告されています。そしてこれは、ニュースでもご覧になっていると思いますけれども、先進国で出生数の減少が報告されています。イタリア、スペインで 20% ほど、フランスでは 13.5%、アメリカでは 4% 昨年出生数が減ったと。これはウォール・ストリート・ジャーナルや日経アジア、そしてアメリカの CDC による統計ですけれども、この下のグラフは日本の妊娠登録の推移ですね。で、グレーの線が昨年なんですけれども、4月に、緊急事態宣言が発令されて以降、妊娠登録の、数が、非常に低くなっていることが顕著です。で、また日本で特徴的なのは女性の自殺の増加です。先進国16カ国の調査では、実はパンデミック以後、自殺率はおおむね変化がなくて、あるいは低くなっているという報告がされています。もちろん、この精神的な苦痛、メンタル面でのうつというような状況が増えているということが言われていますし、今後、どのように推移していくかを見なければいけませんし、低所得国での調査というのはされていませんので、まだ分かっていません。一方、日本では2020年に男性の自殺率は 0.2% ですけれども減った。しかしながら女性は 15.4% 増えているんですね。で、日本での自殺というのは、自殺件数は2011年から2019年までの間は減少傾向にあったんです。ところが2020年6月以降、 3月まで、今年の3月まで、日本の女性の自殺は10ヶ月連続で前年度を上回ったという、で特に若い女性、学生の間の自殺が増えているというのが特徴でした。で、最後にパンデミックによるこうした女性や少女への SRHR やジェンダーの課題が深刻な状況をどのように改善していかなければならないか、何が必要かということなんですけれども、まず SDGs に対する国際的なコミットメントを再確認することが必要だと思います。持続可能な開発目標ですね。そして、SRHR やジェンダー平等を推進して、少女や女性の健康と命に関わるような児童婚や SGM のプログラムの支援を立て直すことが必要と思います。また、取り残される人がないように国際社会のパートナーシップを取り戻して、包括的で包摂的なアプローチを進めることが、ビルドバックベター、より良い社会を構築していくことに不可欠だと思います。また、保健分野のイノベーションを取り入れて活用することができるように、特にオンライン診療ですとか、セルフケアを可能にするインターネット環境整備などのインフラ整備が推進されなければいけないと思います。また、コミュニティで活動する NGO がよりその役割を果たすことができるように支援したり、政府や国際社会に働きかける市民社会の立場、活動の場を広げることが必要ではないかというふうに思います。以上です。どうもありがとうございました。
Thank you very much, Ms. Katsube, for such a comprehensive presentation and all the data and statistics, which has provided us with the stark reality of how in so many ways this pandemic has indirectly impacted women and girls. And this is truly a global issue. And when, as you describe, the heavy impact has fallen on women in high income settings as much as in low income settings. And so yes, the call for international commitment is there. From women now to children, I will now ask Dr. Ogun Dipe to present the pediatric perspective. The floor is yours, Dr. Kemi.
Thank you for this opportunity to share with you on this important topic that is really dear to my heart. Today, we are going to shift to the children after hearing about how the pandemic has affected women. And in this presentation, I'll try and take you through what we predicted or we thought was going to happen after the pandemic was declared, what actually happened, and we'll talk a little bit on what we can do as healthcare professionals or people in the humanitarian sector to mitigate some of those negative effects. So what was predicted? We learned early on in the pandemic that thankfully children were not primarily impacted by the direct effect of COVID-19. But with the complex response to COVID-19, we quickly understood that there were going to be other secondary effects. Depicted here is an example of people trying to make sense of what and how those different factors would contribute to the outcomes for children and women. Such things as health services changes, food availability, economic issues, and education, all of those would interact in a complicated way and would impair maternal and child health and adolescent health in most of the settings that we worked. When we tried to think about how this would happen, we began to think of the different areas or big parts of pediatric and child health. We realized that with the pandemic and the associated mitigating measures, there could be missed opportunities in prevention, changes in how we were able to give vaccinations to children, both routine and catch-up vaccinations. We realized, as Mayumi-san already mentioned, that there would be increase in abuse and neglect also for children because the avenues to detect those were either impaired or children were not being seen in schools and other places where they could be detected, and families were more stressed. We also anticipated that with the pandemic and with the issues with logistics and movement globally, there would be issues with malnutrition worsening in sites where they already existed. and there would be new food insecurity as there was an significant economic impact of the pandemic on the care that we were providing in different sites. We also thought about it, but didn't give much thoughts to it early on, but that there would be a disruption in breastfeeding also, one of the most basic things that we do for newborns and infants because of the fear of COVID-19 exposure of newborns. We also anticipated that there would be some missed opportunities in treatment for one of the biggest killers in Africa, for example, malaria, both in prevention and treatment. We knew that there would be some challenges with essential care for newborns because mothers may not present as often for care, or there may not be staff to appropriately provide the essential care. We also knew that there would be a risk of acute serious infections going undetected or coming too late, and community-based activities that were targeting those infections being impaired during the pandemic. And we also anticipated, and we saw in both developing and developed countries, that there was going to be an impairment in HIV, TB, and other serious chronic disease services. So children were presenting later or not at all when they had signs of HIV, TB, or even cancer. So trying to synthesize all these things together, one of the most famous modeling exercises was put out by the Lancet in the middle of last year. And they estimated, due to these measures taken for COVID, that there could be up to 1.1 million additional child deaths in the next year because of COVID-19. Specifically, they attributed most of those excess deaths to increases in malnutrition and decreases in coverage of antibiotic treatment for pneumonia, sepsis, and diarrhea, which are major causes of pediatric mortality. Even that model actually left out breastfeeding as an essential intervention, but that was quickly corrected by another model added on that looked at the risk of breastfeeding being cut or reduced for newborns, and estimated that that also would lead to an increased mortality. An earlier estimate was a little bit more optimistic, but a later one, looking at the setup or the progression of COVID-19, showed that if we put all those mitigation things into effect and try to prevent mothers from spreading COVID to their newborns, we may save 2,800 newborns at most. But because of those mitigation effects, we were contributing to about 273,000 additional newborn and infant deaths. You can see the big imbalance in that intervention and the resultant outcome. So MSF, understanding quickly that this was an issue that we needed to get in front of, tried to campaign both internally within the MSF movement via the International Pediatric Working Group, and externally with articles about drawing attention to this risk of having collateral damage due to COVID-19, just to draw the public's attention to these concerning trends that we expected to occur. Locally, in many sites, we also try to target the interventions and target the community to understand that COVID-19 existed, but there were other more dangerous problems. For example, in Sierra Leone, malaria continues to be the biggest killer. We wanted that people would focus on that and continue to focus on that and bring the children for care rather than avoiding care because of COVID-19. COVID-19 did not happen in a vacuum. It happened right in the middle of a measles epidemic in Central African Republic, Congo, and Chad. And we sought to draw attention to that fact and show that we still needed to continue to vaccinate children against measles, even in the pandemic. And sadly, we found that we were not able to vaccinate as many children in 2020 as we did in 2019 because of the COVID-19 pandemic and the disruptions. So that was what we expected and what we understood was what could happen. What actually happened in many sites. According to most recent reports, one from the WHO in March of this year, they say that over 1 year into the pandemic, that 90% of countries are still reporting that there have been some disruptions in their services. And these disruptions range across different services, and we'll cover a few here. And they have been significant in many areas. Specifically, one study by the Global Fund looked at 32 countries, 7 in Asia, and looked at the disruption in their services. What they found was that there were some issues that were related to changes in resource allocation, meaning that people may have sought care, but they had issues with accessing the care, either because the services were reduced, not existing, or canceled. The waiting list for certain services got longer. Some facilities were just closed. And on the other side, people also changed their behavior about seeking care, meaning that they did not sometimes want to seek care because they were scared of COVID-19. They couldn't get to care even if they wanted to because of this, the mitigating factors, lockdown, transportation. And so both resources for healthcare and health-seeking behavior were compromised. Looking at some basic healthcare activities that should have been occurring, we saw that in the African country survey, there was a 5% decrease in ANC services, antenatal care services, and 66% in those 7 countries in Asia. Under 5 consultations where children come in to be seen for simple diseases or serious diseases dropped by 23% in Africa, and also dropped a lot in Asia. Zooming in on and looking at the complex effect of health-seeking behavior changes on healthcare outcomes. Here's an example from our MSF site in Sierra Leone. We have a pediatric hospital there, and Sierra Leone has a specific history of being one of the few countries in West Africa in 2015 to have experienced for the first time the Ebola epidemic. It was particularly devastating there, and there was a lot of death, especially with the health centers being the focus of that, with people realizing that 60% of people went to hospital and never came back. So when the COVID-19 pandemic hit, one of the things that was passed on in information, even from the government, was that this was worse than Ebola. And this led to the re-traumatization and memory of what had happened then, and many people not seeking care because of that fear of interacting with healthcare. And you can see here that due to that, we in April and May and June of this last year saw a great decrease in the number of children presenting to the hospital. These are children who normally require inpatient care, who are very sick. And this is not a normal trend, because in April, May, and June is where the rains are starting, and we expect more malaria, which is a primary morbidity scene. So you can see that healthcare seeking behavior was definitely impacted in a negative way. When we look at all the services for reproductive, maternal, newborn, and child health, we see that there was a significant disruption with about 35% of countries reporting some disruption in that. When we look at the ones that were most disrupted, we see family planning and contraception services really disrupted, which will have significant impacts for maternal and child health later on. We saw that management of moderate and severe malnutrition was also impacted greater than 40%, which I'm sure has led to increased morbidity and mortality in the vulnerable group. When we look at newborn care, we see that in a survey that was done across 62 low and middle income countries, that there were several challenges with providing neonatal care. Nearly about 30 to 40% of the time, there were issues with having enough staff to provide care in neonatal units and having enough capacity to provide it in terms of space, because some places were taken over for COVID-19 wards and things like that. Outside of that, we also saw challenges with the babies being, with caring for the babies, also with there being a tendency to discharge babies earlier because of space issues, because of COVID fears, and also families choosing to leave the hospital earlier, maybe sometimes when it was medically not advisable because of the fear of COVID-19 exposure. Among healthcare workers also, we saw the concern about COVID-19 exposure for the newborn, and we saw that 2/3 of healthcare workers did not allow mothers to have kangaroo mother care for their children, even though that's a life-saving intervention. And even when the child was found to be negative, or the mother was found to be negative, they were still not providing this essential service. So it was greatly impaired during this time. Focusing on an example from MSF again in host Afghanistan, this one is one of our biggest maternities and is usually busy with about 2,000 deliveries a month. Because of the during the COVID pandemic, in the early stages, we had a few staff who had COVID-19 exposure and who had to be quarantined. Because of the strain and the risk of continued exposure, they made the decision to limit the number of visitors to accompany women to one per woman, delivering woman. And that was something that the community did not find acceptable. And because of that, we saw the deliveries drop from 2,000 a month to 1,000 a month. And that you can see in the solid line going through the month, the resultant drop in neonatal admissions and exits from our neonatal ward. We know that in this period that some mothers did seek to deliver in other health facilities, but we also know that some just chose to stay home, which increased the morbidity and mortality for both the mother and the newborn babies. When we look at vaccination services, we also know that they were disrupted. And we see that about a third of countries say that they had some disruptions in services, both in the routine ones and in the ones done in the community and outreach services. When we look at malaria, which is usually the most of the burden is in children under 5, and 94% of the cases are in Africa, we saw that there was a lot of disruption of services, both for prevention in terms of insecticide-treated nets, spraying of houses, and in treatment. We see about 50 to 60% of the malaria diagnosis and treatment facilities were impaired during this time, and that translates directly to increased morbidity and mortality for children. And we saw that in some sites, about 1 in 5 sites in the African countries surveyed had a stock out of anti-malarial treatment, so they could not provide anti-malarial care for children under 5. This translates definitely to real deaths in the community. Other services that we know that were impacted in general, but definitely affect children were services for HIV and TB. HIV for the detecting and treatment, and onward referral for further evaluation was impaired. TB continues to be a problem. Childhood TB is criminally underdiagnosed to start with, and in this period of the pandemic, TB referrals, which means onward referral after a suspected case is identified for evaluation and maybe enrollment in the national program, dropped by 60% and is still going down. So this is a concern that we're losing a lot of ground in already a poorly covered field. Mental health services, which have been also notoriously bad in general in most sites, were very, very badly affected, with some sites reporting up to 80% loss or disruption of services in mental health. Surprisingly, also, we are seeing up to a 20% reduction in emergency and critical care services. This means, life-saving care, transfusions, emergency care, ICU care, people who are critically ill, and up to 20% of the time, they were not able to receive the care that they needed. That definitely translated directly to immediate mortality in a lot of cases. And when we think of pediatric healthcare, we also think about other things that are contributing. And as Mayumi-san has already mentioned, that there is an anticipated increased risk of early marriages in young girls because of the pandemic. Specifically, school disruption will accelerate or lead to some of these changes, because with schools closing, there are increased dropout rates because people don't return to school, and families take that as an opportunity to initiate the early marriages that the school enrollment was preventing. And we tend to think of it as, okay, just a societal problem that has happened, but it does translate to morbidity and mortality for both children and the girls delivering. Here's an estimation from a study of what could be expected from these school closures in terms of both the total number of girls who had to drop out of school and what that means for maternal deaths across 6 Asian countries, what it means for neonatal deaths, what we expect to see in terms of low birth weight infants, and even past the neonatal period, the issues of impaired growth like stunting in this population because of that. In South Asia alone, we see that this is a problem, and this is looking at the demographic health survey from 6 Asian countries, and just taking everything to be equal, there was definitely an increase in mortality, both for children and women during this period that could be attributed to COVID-19. So what can we do? This is the big challenge and the big question that we hopefully can face together. One of the first things that we have as an advantage is that we, at this moment in time, have more access to data and more quick access to data than we ever had in any other period of history. So we can have this information very up to date about what is happening on the ground in all these sites. And we can tailor or target our monitoring and surveillance to focus on the countries where we anticipate that there is a higher risk of these issues becoming out of control, both because of the pre-existing problems or because of what happened during the pandemic. We also have to be proactive in many ways. One of the first things is to think about innovation. We have to think outside of the box or try new things where we hadn't before in terms of differentiated models of care for certain medical conditions, trying new environmental and other solutions to try and reduce some environmental associated diseases like malaria. We have to think about the SDG goals that we say we want to move slowly towards a certain goal. We may have to think about accelerating and moving faster and doing and turning on pumping on the gas, as we say, to get to those goals much quicker, because we don't want to be caught falling backwards again in the next pandemic or another situation. So we know the things that improve pediatric and maternal health, such as having safe deliveries, being able to assure vaccination, provide nutrition in a world where there's enough food for everybody. We know that these interventions are there. We have to now put our money where our mouth is and go towards those solutions before the next big event happens. We have to now think about the equity of healthcare delivery all over the world. As we already mentioned, that for women's health, that the lower income countries bear the burden. We have seen in this pandemic very, very clearly that political will is very, very important and can greatly influence how things will go. We found out in this pandemic that within 9 months, one can find therapeutic solutions for coronavirus and more than 10 vaccines that are effective against the coronavirus, a virus that was typically thought to not have a chance to have a vaccine in the past. So this is what we need to turn this political will to things like old players like TB and malaria to target them, because we know that if people put their minds and their will and their resources to this, they probably could find the solutions as quickly as they did for COVID-19. The last thing that we need to think about doing is resilience and building resilience in the communities we work. It's easy for us to, as an international community, come in and support from outside with external support, but the harder work and the more important work is to build infrastructure and human resources in all the sites where we support, so that when we are disconnected or we are cut off in the next pandemic or because of other things, we will not have the challenge of having to disrupt services because of that situation. These are the things that we have been, some examples of the things we've tried in different sites because of the pandemic, some that were already in operation, but some we pushed for, such as increasing or trying different TB regimens for children during the pandemic, doing family-based TB treatment during the pandemic rather than facility-based. Some facilities in Sudan, for example, tried to do mother muak, which is screening for malnutrition done by the mother at home, so that we would reduce the risk of COVID exposure for the community health workers. And this pandemic has shown that we can try to plumb the new connectedness that we all have in terms of mobile phones and media, to try and use that for medical consultations, scheduling appointments, and those kind of things. So with those things together, I think if we look forward, we can try to mitigate some of these effects of COVID-19 on children, but we do have a lot of work to do. Thank you.
Thank you, Dr. Kemi, for sharing both the global picture in such detail and the situation as well faced specifically with examples from our MSF projects on the wide range of impact on children It's very worrying to think of the increased number of children that have died due to the impacts on our malaria services, on nutrition programs, access and coming to emergency services, and even more scary to think of the future deaths that will continue to come with these interrupted services, but also with the missed HIV screening, with early TB diagnosis and missed vaccinations, like routine vaccinations. I was surprised though to hear that even there's been an impact on just the most basic of the, life-saving and newborn care methods, such as the, reduction in breastfeeding, discouragement of kangaroo mother care. And I think this really shows that cannot underestimate the impact of fear as much as the unknown, that it even disrupts methods that we know work. So as you say, we need to innovate, accelerate, anticipate. We need to ensure equity and build resilience. So let us now hear from Dr. Azim, who will share with us how they have managed actually to continue to provide vital maternity services in Peshawar, in Pakistan. And the floor is yours, Dr. Azim.
Good evening, everyone. Thank you so much for inviting me to the Congress to speak about women and child health in Pakistan. I have a presentation to share. Pakistan, when COVID-19 hit Pakistan in February 2020, it put a lot burden on the thriving economy and health system. We were already struggling hard to gain our targets for the sustainable development goals in health, and we had many unmet needs. This COVID impacted us and put a lot burden on that. Pakistan is the 5th most populous country, and it ranked 152 among 189 countries on Human Development Index, and it is ranking lowest in South Asian countries except Afghanistan. There was an analysis of global disease burden published in 2016, and Pakistan ranked 149th among 188 countries on the first global assessment to assess countries' progress towards the United Nations health-related sustainable development goals. The slide shows some indicators from the country. By 2018 estimates, population of Pakistan is 212.82 million, and 49% of it comprises of women. In 2018-2019 statistical report from Pakistan, it shows that with higher fertility rate and lower contraceptive prevalence, we are having an ever-growing population with a population growth rate of 2.07%, which is a reason that we are facing difficulties in implementing health strategies in the country to gain the targets. If we look at the figures, Pakistan has an estimated 298,000 annual neonatal deaths, which accounts for 7% of the global neonatal deaths. The perinatal mortality in Pakistan is 57 per 1,000 total births. And if we look at the maternal death numbers, the maternal mortality rate was 140 per 100,000 live births by an estimate in 2017. And a stand-alone Pakistan country-wide survey was done on number of maternal deaths, and the maternal mortality ratio was found to be 186 per 100,000 live births. This survey was done in 2019. The lifetime risk for a woman to die during pregnancy due to complications of childbirth and postpartum period The lifetime risk is estimated to be 1 in every 143 women in Pakistan. Here I would like to add that all these figures are actually from the household surveys and from the community-based health worker data registers. So the number give an estimation of the situation, but the reality can be even worse. Among all the provinces of Pakistan, Khyber Pakhtunkhwa, KP, has the lowest rank on Human Development Index. KP is the third largest province of Pakistan, which is in terms of economy and population, and it is situated among the northwestern region along with a belt of federally administered tribal areas. This FATA stands for Federally Administered Tribal Area, and KP province altogether is having the lowest numbers of health indicators. We are performing poorer. According to 2017 census, the population of KP was 30.5 million, with 80% being the rural residents, and the FATA has a population of 5 million with more than 90% residing in rural areas. Adding to that, the 2019 annual report published by District Health Information System of Khyber Pakhtunkhwa, the numbers for the mortality stated are 34 per thousand total live births is the neonatal mortality, and 132 per 100,000 live births is the maternal mortality for the province in that annual report. That report is actually prepared by data collected from primary and secondary health facilities, plus from the lady health worker, which are community-based workers, and they collect data from different from their catchment areas. So it's the figures which are shown in the district health information report is from those references. Along with the Pashtun community of Khyber Pakhtunkhwa, because we have a long border shared with Afghanistan, so KP is the province which is hosting 62% of all the Afghan population in Pakistan. And it is approximately 1.5 million by the December 2020 figures. Low socioeconomic status, lower literacy rate, restricted awareness or lack of awareness of women about their rights, or lack of awareness of the health components available for them, plus restricted access to the facilities, make health status of KP very much compromising. In Khyber Pakhtunkhwa, we have highly patriarchal society. Women do not have right to speak. Women do not have right to their health decisions, health-based decisions. And they have limited access to information and limited mobility. Because of that, women and subsequently children are the most vulnerable population in Khyber Pakhtunkhwa. Considering all these poor outcomes for the women, or poor numbers for the women and children, MSF has started a project which is maternity-based 23-bedded hospital, and it provides comprehensive emergency and obstetrical neonatal care to the marginalized community of Khyber Pakhtunkhwa. To give you more insight of what is actually health indicators for the province, I go to this previous slide. It is the 2018 Pakistan Demographic and Health Survey concluded that the rural population is having the worst numbers because they have higher mortality rates because their antenatal care provided by skilled provider is less, and the hospital-based deliveries in rural areas is very less comparative to in general Pakistan. Because KP and FATA is having more than 80% rural population, the numbers are very low for KP. So if we see that the fertility rate for KP rural area and then for FATA, these are highest among the provinces of Pakistan. And similarly, the hospital-based deliveries are very less, and the skilled provider for antenatal care and for deliveries are not at good levels. For the Peshawar Women Hospital, the hospital which is run by MSF in KP, if I give you a brief geographical aspect and the catchment population for that. So we are located in Peshawar. This is the map of Khyber Pakhtunkhwa. We are located here in Peshawar, and we are covering the adjacent areas of Peshawar. Those areas which have high Afghan refugee residents, and those areas which are considered remote or suburbs of KP, rural population. Plus to that, we also manage to have population from the western border, this federally administered tribal belt, and we are having patients from here too. So in 2020, a total of 6,671 patients were managed in Peshawar Women Hospital. 80% of them were from our targeted areas, including more than 1,000 Afghan refugees and more than 2,000 patients from FATA. How COVID-19 started affecting Pakistan? With all this background of the health status, if we see that when COVID-19 came to Pakistan, initially the situation was not very clear. There was slow responses, inappropriate strategies to contain the disease, which put the continuity of healthcare on stake. We had lack of health staff due to illness or due to the number of sick outrun the number of health workers, and that lead to closure of many of the centers. Adding to that, because family planning and post-abortion care services were considered non-essential, so they were closed by the government order. And adding to it was the lockdowns. There was disruption of supply chains. Because of the lack of transport, it was difficult for women or public to reach to the hospitals. And even when they reached hospital, the hospitals were so low on resources in terms of healthcare providers, in terms of bed available for the sick, that they were not able to entertain them as it was needed. With all this, an additional challenge was to educate people. People in Pakistan, it was difficult to educate them about the disease. It was difficult to educate them about the preventive measures because of the misconception and the propaganda against disease and vaccinations, that stating that it's a Western plot to affect the Muslims, or relating their illness to their religious belief instead of considering or acting for the cure or for the prevention. So it all made difficult for health workers or healthcare providers to overcome the disease burden. It was a situation of concern because healthcare was not easily accessible. So especially women who were uncertain of the disease effect on their pregnancies, and the mothers who were worried for their children. They were anxious and they had anxiety and fear that when it will be not possible for them to reach health facility and gain the care which is needed. So it put a lot pressure on their mental stability. UNFPA had a brief about situation in Pakistan, situation of COVID in Pakistan in May 2020. And they estimated 20% decline in all health reproductive services. Family planning was among the most affected because public sector and private sector family planning centers were all closed. And because of the lockdowns and disruption, there was stock out of contraceptive methods. And it was estimated that with 20% decline, there will be additional 1 million unintended pregnancies in Pakistan, with almost 400,000 additional unsafe abortions. Pakistan already had 5.5 million women with unmet needs for contraception. And with this 20% decline, UNFPA estimated that there will be an additional 2.1 million women with unmet needs of modern contraceptives. Similarly, regarding gender-based violence in Pakistan, we already have 8 million women, and it is estimated that 8 million women face some degree of physical violence in a year in Pakistan. With 20% decline, it was estimated to have increased risk of violence during lockdowns to an additional 1.6 million women. A more recent analysis was done by UNICEF on direct and indirect effects of COVID pandemic and responses in South Asia. And it stated that in the initial phases in Pakistan, there was 31% disruption of health activities. The healthcare components which they assessed included family planning, antenatal and postnatal checks, immunization and vaccinations, and facility-based births. So in the initial period, we had 31% of disruption of all the health coverage. And it increased to 50 to 70% by mid-year 2020. This analysis reported that it leads to 14% increase in number of deaths in children less than 5. It had an additional 11% number of stillbirths, a rise of 21% in the number of maternal deaths. The analysis reports that 234,978 unintended pregnancies occurred because of this disruption, with a 20% rise in unsafe abortions. With all this situation in Pakistan, how actually COVID-19 affected us being working in the field? We had a lot of challenges during this period, especially safety to work and how to continue giving essential maternal health care services to this community in the time when other facilities were closing down and they were running low on their resources. Adding to that, adaptation of continuously changing COVID guidance was also a challenge. If I list the challenges that we had due to non-availability of flights and difficulty in getting visas, in the project we had long expat gaps. At times it was 1 or 2 positions who were covering the rest with additional workload. Plus to that was the shortage of national staff. This was secondary to sick leaves of isolation and quarantine. Plus, because we adopted health risk-related strategy for the safety of our staff. For example, those who were having high risk of age more than 60, or those who were having comorbid situations, we asked them to avoid work. Plus, the lockdown and the disruption of the transport made it very difficult for the staff to reach hospital. So it all created a shortage, and it was very difficult to deal with to continue the activity at that time. With all this, there was a constant update of the COVID guidance regarding regarding the disease, regarding the workplace activities, how to manage health facilities in this COVID phase. So it all put a lot burden on us to understand the disease, plus to keep running hospital at the same time. There was closure of MOH hospitals, especially even the big maternity units in Peshawar, plus their OPDs, all were closed either by government order to divert the resources towards the disease, or it was because of their staff isolation. So we wanted and we needed to work in this situation to continue to provide maternal health care services to the community, so that the gap that they are getting from the public sector hospitals, at least we can put some efforts to help them. Plus to that was collaboration with the external facilities. Visiting the partner hospitals and reinforcing collaboration in future in case if we have some referrals for the continuity of care was very difficult. We are still having difficulty in this regard because of the because all the hospitals are overwhelmed with COVID cases, and they have their own limitations of bed capacity and HR, and they have their own challenges. So it is very difficult to maintain a close liaison with them in terms of our patients getting a continued care when we want them to refer to the other hospitals. We, with all these difficulties, we temporarily suspended our activities for 6 weeks only, and we accepted the challenge. We prepared ourselves, and when we reopened, till now, we are continuing to work without any interruption. In this time, constant psychosocial support for our staff and reminder trainings for the staff to maintain the quality of care is an ongoing process for us. Our staff being flexible and willing to serve in this crisis and very motivated is our key strength. The time when we were closed, we utilized that time to establish our infrastructure, to plan an uninterrupted supply of PPE for the staff, for the disinfectants, the alcohol-based hand rubs availability in the hospital. We adopted the ever-evolving and the new guidelines to develop SOPs for the care of patients, for the staff, for the hospital. And we are continually doing our services to help community have lower mortality rates in terms of maternal and neonatal child health, and we are determined to do so. If I share some of the numbers that we managed in 2 years, 2019 and 2020, our baseline, our average activity never stopped. And we had a 14% decline in year 2020 if we compare it to the 2019 activity. And this decline was mostly the contributing part of the year was the second quarter of 2020 with the months of April, May, and June. And soon after reopening in June 2020, we regained our baseline activity, which is about 500 deliveries per month. And as the time continued and as the COVID was affecting the public sector and the private sector healthcare facilities in Pakistan, our activity started increasing, and we increased up to 20%. And in later half of 2020, we even managed 600 deliveries per month in Peshawar Women Hospital. We are determined to work in this crisis, and we are having plans and SOPs, and we are determined to continue to serve. Thank you.
Thank you so much, Dr. Azim. That was a very clear explanation of the situation that you're facing in Pakistan, specifically in the KP province. It really is challenge on top of challenge, and yet you sound so determined to keep serving the population, which is great. I also want to thank you personally for joining us again on today when it is Eid. Also thank you as really overall, I don't know if it's really on behalf of MSF or in general, and also to congratulate you and your team and all the staff that's working at Peshawar Women's Hospital, but also the staff working to keep the medical services going there, for accepting the challenges, as you so positively just mentioned, overcoming those challenges, and ensuring that you can continue to work to serve the women and babies, not just in Peshawar, but as you said, all the adjacent areas as well. Your activity data, they speak obviously clearly for themselves of what you've managed to do. You've managed to maintain the quality of care and the level of services despite all the COVID-19 challenges and the measures and the strain that you've had on human resources, etc. So I really want to thank you and all your staff for this flexibility, maintaining your motivation, staying determined, and your dedication to your patients despite this crisis. And I mean, it's because of the COVID-19, we are where we are now. We are in this webinar setup. And if it wasn't for that, I would say this really would have been a moment for a big round of applause for all our three speakers, representing their colleagues, their organizations, their staff, their team members, who have continued to deliver assistance to those who need it most. But that applause, I would say, goes out to all of you as well in the audience, all the participants. Amongst you, there are medical workers, field workers, there are students, policymakers, researchers. I can't list all of you, but thank you also for all your efforts, both here in Japan or abroad in any of the other countries, as is your continued support and your endless passion, which is why we are here now together on a Friday evening. So with that, I would like to move to the Q&A session. And as moderator, I would like to kick off with some questions before opening it to the participant questions. In the meantime, I think I've seen participant questions coming in, but for those of you who haven't posted your questions yet, please start to post them via the chat system. And I'm just going to kind of, because of the time, I'm going to sort of limit a bit the questions that I have per speaker, and I'm going to go in a bit reverse order. I'm going to start with Dr. Azim, just in case you may need to to go early. Just don't hesitate. So Dr. Azeem, I'm going to start with asking you that you've described amazingly the maternity services that you guys are providing at the Peshawar Women's Hospital. But I just wanted to know, how else have you been trying to reach your targeted community and population?
Sorry, Clara, can you repeat the question?
Sure. I was just saying, because you've been describing your maternity services at Peshawar Women's Hospital, but I was wondering, how else have you been trying to reach your target community?
Okay. Actually, if you see, we are in Peshawar and we target not only surroundings but also the tribal belt near the western border. We have a outreach team with a very strong motivation and a strategic plan for the outreach activities, and we reach our population through them. We not only have hospital-based visits through these outreach activities, but we also meet community in those targeted areas. And the main focus is to not only introduce ourselves, but to educate them about the availability of all the services that is available to the community. It helps us educating them on the antenatal care and the need of postnatal visits, and plus to that we give them information that what services we are doing. We introduce to the community the locally situated primary and secondary health services in their region from the government of Pakistan. So it gives them a sense of trust to those facilities, so that they visit there and they can have a better care while they are pregnant, or they have a better care for their children. This outreach strategy is helping us a lot to reach that target populations.
Thank you, Dr. Azeem. And I think that sounds like a really important sort of strategy, especially when I've heard from you, I've heard from Dr. Kemi as well, about the amount of fear that has impacted on the health-seeking behavior, and people not seeking. I mean, from all three speakers, we've heard this. So I think this sort of what you've been doing with this community outreach sounds like it's probably a crucial strategy that we need to be implementing. I'm just going to, sorry, I'm just wary of time. I did have more questions for you, but I might move on to another question to another speaker and see if you can stay on or not. And I think it's just because we were talking about this, I mean, fear, lack of information, the impact of that. And so Kemi, I wanted to ask you a bit the next question. I mean, this clearly has been described by all three of you as having have a significant impact. And I was just wondering are there better approaches, because you mentioned about innovation or innovative approaches, are there better ways or things that we need to consider with how we communicate or pass on information in order to tackle this? I'm just wondering if you might have some recommendations on that when you're talking about innovation and how we can prepare for the future as well.
Yes, for this topic, it's interesting. When I was listening to, and some questions already been asked about this, it seems like the solution to this problem of fear and lack of information is both new and old. The old solution is one that we tended to neglect in the past, which was real community engagement, meaning that we don't do things to the community and for the community, we do things with the community. And this is one of those successes that we saw with this pandemic compared to West Africa with Ebola, where realizing early that this was going to be a challenge and those issues of fear and lack of trust were already starting to pop up. The first question was to ask the community, meet with them and say, what do you need? What can we help you to do to reduce your fear. And in Sierra Leone, for example, one of the answers they gave was, can we at least have a water point always stocked with water and clean water and soap installed in front of each of our villages, and somebody there oblige everyone to wash their hands on arrival to the villages. We facilitated that for them, just to meet them where their need was. And also with that, we then went, and because we're engaged with the community, we're able to understand quickly what those specific rumors, those specific beliefs were that were popping up, and target the messages and the responses to those. So it seemed like people's minds were being read by the answers we were giving. So that's one of the basic solutions that we tended to neglect in the past, that thankfully in a lot of sites we're learning that if we are engaged with the community and we from the beginning are in lockstep with the community, then we can anticipate and also address the needs as they come up without finding out later on that something had been going on and we didn't notice. The other side of that also is that we also have to catch up with some of the things that have happened since we started humanitarian work, and that is more connectedness with media. Some things that we didn't do before, we should try and do now, with being able to contact people directly via their phones, even provide phone credit for people to be able to reach us for medical questions, so that we can have a hotline that is free for people to call if they have those questions to ask. We can do peer-to-peer networking where we didn't before, especially for the young people, so that we would have people who are champions who understand more about COVID and who are in those groups to immediately counter any of those beliefs. And then we can use social media. Some of us are not as adept, but we can learn how to use things like Facebook, Twitter, and all those kind of things to target and to embed ourselves in the communities and dispel some of those issues of lack of information or fear about healthcare.
Thank you so much, Kemi. And Katsube-san, that's exactly what you also alluded on in your sort of last slide as well, about the use of the digital information. I was going to ask you come to another question specifically with your presentation, Ms. Katsube, but I don't know if you wanted to add anything to what just Kemi was saying on that.
そうですね。ジョイセフが実施していることというのは、現地の中でいかにコミュニティでサービスを届けるかということなんですけれども、やはりこれからこうしたパンデミックが起きるような時にですね、新しい方法、技術というものがよりよく使われるためのインフラストラクチャー、発表の中でも言いましたけれども、インターネットですとか、そうしたものが広く使われるようになるということがすごく重要ではないかなというふうに思います。実際に、直接現地で活動をする人たちにとって何が一番使いやすい方法かということで、限られた、いろいろな、新しいサービスに対して、農村に住んでいる人たち、変革地に住んでいる人たちがいかに、アクセスしやすい方法を紹介していくかで、その環境を整えていくかということが非常に重要だというふうに思います。
Thank you. Sorry, I just was catching the end of the translation. So thank you, Katsube-san. And I just had one more question before, and I think I'm going to probably have to move because I'm seeing the list of questions coming from the participants. But it's just because there's one thing that you did talk about, which was the need to restore funding and the diversion of funds from SRHR programs, from vital programs like eradication of child marriage, female genital mutilation, and really the impact that's had. Clearly, either because of funding having been diverted to COVID-19 needs, or has it actually been more about also the impact of the negative economic growth and financial losses that overall has been felt, and has that impacted in general, like the funding towards women and women's health services. So I just wanted to ask if you could explain your understanding a bit more on, is it really about diversion, and is this going to potentially be rediverted back, and not just funding actually, so human resources, or are we looking at a more long-term cuts to these funds, which because in general there's this huge economic impact?
はい、SRHR プログラムだけでなく、通常の保険プログラム等にへの資金が削減されているということは、まず第一にそのパンデミックに対する対応に大きな資金が投入されたということですけれども、パンデミックによって経済的困難が生じていると。で、各国政府が財政的に疲弊していく、またはその国際産業への打撃がある。で、それからそうしたことで、この先、将来的な財源の縮小も予想されているということで、そうしますと、各国または国際機関へのODA の拠出金ですとかカットされてしまうという動きが実際すでに出始めている。で、そうしたことの懸念が非常に大きくあります。で、また国レベルでだけではなく個人レベルで職を失っていく、そして女性たちが暮らしを取り戻すという道のりも非常に困難なことになっていくのではないかなという懸念はあると思います。で、そうした中で、やはり、限られた資源といいますか、限られた資源をいかに有効に使うかということが必要ですし、じゃあ果たして本当にもういろいろな、他のプログラムに使う資金がないのかって言いますと、実際はそうでないかもしれない。だからそこは精査していかなきゃいけないですし、効率的な資金の活用ということをしなければいけませんけれども、プライオリティをこれはプライオリティの順番というよりは、どちらかというと人権の問題としても捉えていくことが重要ではないかなというふうに思いますし、ですから、もちろんその、COVID の対応に非常に大きな予算が必要である、これからワクチンも支給していかなきゃいけない、そういうこともありますけれども、一方で、じゃあその陰に隠れた人権に関する基本的人権に関わるような生命や健康に関わることをないがしろにしていいということにはなりませんので、そこはやはり限られた資源をいかに有効に使うかということを工夫していかなきゃいけない。本当に経済的な困難というのは当然予想されているわけですけれども、その中でも対応して知恵を出していくということが重要ではないかなというふうに思います。
Thank you, Katsube-san. And actually, I'm just going through the participant questions now, and I might sort of then move from that to the issue of political will, because there was a question from the audience and to Dr. Kemi, saying Dr. Kemi mentioned about power of political will. What can we do together to change political will? And maybe I'll see if other speakers want to chip into that as well, but maybe Kemi, you want to start?
Yes, this is a big question, and one where we do need to sort of be all on the same page for it to actually work. But the interesting thing for this moment in time is that we are in a time where we are more connected than we were ever, so that you can hear about one event happening in one part of the world and everybody in the world can rally around and understand it almost immediately and be able to respond to it in a knowledgeable and in a targeted way. And this is what I think needs to be done for this situation, where if we from different sides unrelentingly put pressure on our different organizations, our government, people in positions of power to draw attention to the situation and to demand that something be done, and not accept half measures and not accept people just saying that's a good point, we'll take it under advisement. If we can sustain, and that's a problem, we tend to have fads. We think, oh, this is a sad thing and this is happening, and then we move on to something else. If we can keep the pressure on in a diverse way, in an unrelenting way, and using different channels, and the younger generation knows how to do this best with targeting through social media, through their disseminating information, some of this information, this will be what we will be able to use to change the political will. Of course, there are big actors like in MSF. The Access campaign helps a lot with putting that pressure on. And if we find a good interaction or good setup where we have both lay people putting on the same pressure, using the same messaging as these big organizations like MSF Access campaign, we would find a solution both in the developing and developed countries where people will know about the issues and then will know that they're pressured by their citizens to respond to them.
Thanks a lot, Kemi. I don't know if either Sobia, do you want to say anything about what would you consider as how can we change political will?
Yes, I would say that like we do in Pakistan, it's like there are groups, activist groups who actually see into the real community-based or root level issues with the community, with the public health, primary and secondary level public health facilities, and when they come up with this compromised figures, those groups and those NGOs, and same as like for us being MSF members, we went talk to the authorities in the healthcare system, the district health officer or the director general, KP, the director general of health in KP. In these meetings, actually, we highlight these issues of low resources for the community, or we highlight the issues of non-availability of trainings or skilled birth attendants to the far-flung and remote rural areas. So this gives a sensitization of the problems at root level. And I think to change the political will in broad spectrum, it is at some point it is our responsibility and our role to participate and to sensitize and to raise the awareness, so that they know what is happening in the community and what is actually needed to be done. For example, if I mention that in past years in Pakistan, some of the organizations which were working in family planning and reproductive health, they made a framework and they raised an initiative to put family planning services as an essential component of the health services, and they put forward this to the government officials, and it is almost approved, and now it's an achievement for us. Similarly, when we had sustainable development goals and we participated in that, now with the community workers, their relation with the local body government, it creates a program, a pathway of flow of information from us to them, and then they make some legislation and acts in the assembly, and which is very helpful. Especially if I talk about Khyber Pakhtunkhwa, we recently had Public Health Act, which is actually focusing on all the health aspects for women and children. We also have Mental Support Act, which is for the women and all other mental disabilities, plus women who are facing difficulties at social level or facing violence and then leading to the mental instability. So all this, I think, is a way to change the political will.
Thank you very much. I mean, Mayumi-san, you've already kind of alluded a little bit on it, but would you like to add anything before I move on to another question?
Sorry. I'm looking at the questions from the audience.
Sorry. Yeah.
Sorry.
It's fine. Actually, maybe then I can also, because there was a specific one for both Joseph and MSF, so I might take the opportunity to ask this one. And it says, for Joseph and MSF, what was the most unpredictable? I mean, we've listed, a large list of potential predictable problems and what actually happened between the speakers. But I said, what was the most unpredictable problem at the time of the pandemic? In terms of women's and child health, and what is the biggest internal challenge, such as shortage of medical staff, which I think you've all mentioned. And I might just ask then Katsube-san if you could start with that one.
Hi. COVID が起きたときに、何がアンプレディクタブルだったかっていうことはとても難しいことなんですけれども、こうした状況の中でどのようにジョイセフが現地での活動を続けていけるかということが、一番大きな課題ではありました。昨年の3月に現地にいたスタッフが全員引き上げてこなければならなかったという状況の中で、じゃあこれからどうするかということでしたけれども、結果的には遠隔での業務を継続していけたということはありました。で現地の様子がなかなか最初分からなかったですけれども、少なくともコミュニケーションが取れていたということは本当に良かったと思います。で最初はすべてが本当に、予想できなかった状況ではありますけれども、この1年間の経験の中で、ただ、ジョイセフというのは非常に国境なき医師団やICRC のような、紛争というか非常に厳しい命の危険と背中合わせというところで活動するわけではないんですけれども、なかなかそう変化を起こす、成果を出すことが非常に難しい妊産婦死亡を減らすとか、例えば、何ですかね、予期しない妊娠を減らすとか、行動変容を起こさなければならない活動をしているので、そうした活動をいかに継続するかということが、やはり大きな現地の活動としてもそうですし、ジョイセフの中での課題でもあったと思います。
Thank you, Ms. Katsube. I might ask Kemi if there was anything that you might want to add about unpredictable sort of problems. We've been in many discussions together in the pediatric working group. I'm just going to ask you, Kemi, because Sobia, you've given us a very detailed list already of the challenges that you faced in terms of having to even close the hospital for 6 weeks, but use that time to be able to prepare the hospital to restart activities, but as you mentioned, staff illnesses, etc. So I feel like I might just ask then, because Sobia, you've covered that in so much detail, I might ask Kemi if you might have anything to add about what did we from MSF perspective face in terms of unpredictable, what was the main unpredictable problem actually?
Yeah, for us, I think there were two. Spreading that the issues with HR, of course, was very well described by Dr. Sobia in Pakistan. Now, stepping back and looking at it from an international perspective, we did not know or did not anticipate how the pandemic would affect our staff internationally. In the past, we've had international and national working together, and we understood that, of course, we were going to a place that may have instability or challenges, but people are coming from outside and interacting with people inside. In this situation, the pandemic, every place was having issues with instability. So this was the part that we did not, led to very unpredictable action by our staff, because half of them were worried about what was happening at home, how to support their families during this period of time, whether their borders will be open, things that were not ever on the radar before. So this was a very complicated thing that most people did not anticipate or understand how to deal with at all, especially when all the borders closed and families were separated and people were unable to see their family members. for a whole year for some of them who were working in different sites. And the other big one that was interesting that we definitely were not prepared for, was very unpredictable, was how the disease, the epidemiology of COVID-19 itself. We expected, with looking at the data from the developed countries, that this would be magnified in the developing countries in terms of morbidity and mortality, and that was not the case. And this was something that in many cases we had already thrown a lot of resources and planning at, and then we realized that that was not what was developing, and then we had it in other places where we didn't expect it, or later than we expected. And this was the part that was very unpredictable in trying to support our sites during this.
Thank you very much, Dr. Kemi, for elaborating on that. There was one very specific question to Dr. Azim, to Sobia. I'm just going to read it out. It says, as you mentioned, religious beliefs sometimes might be an obstacle when MSF tries to provide healthcare. How do you convince the women and moreover men in Pakistan to accept the healthcare they should have? It's quite a challenging question.
Thank you for the question. Yes, it is challenging, but it is also challenging to convince them. It is very rightly said, because the community that we have is like, they prefer to be delivered at home, and they prefer to be delivered with someone who is known to them. But on the other side, as I said, the outreach team that we have is not only doing the hospital visits, but they are also doing community visits. So they meet somehow some influential community members of that community, which we call Malik, or the senior person. Plus, they meet the men, local men, and they meet women in different gatherings, to tell them with the statistics or with the examples from our own hospital, that how we have women in a bad situation when they are not properly taking antenatal care throughout their pregnancy, and how we get them when they are already being using some drugs which are not supposed to be used during pregnancy. So what complications we get for those women in our hospital, and how difficult then it comes for the health workers to give you the optimal care. So with all those examples, living examples, you can say, that we share with them our own experiences, not mentioning the patient, definitely not compromising their privacy, but we mention them their experience, our experiences, that what has happened to women if they are not in the proper healthcare system. So this gives us a good response from men. Secondly, what my personal opinion is that the society is in KP is they are more happy if you involve men in decisions more than women. Because when you let women do their decisions for the healthcare services, to go to hospital, to see a doctor, they are not able to convince their men or their family seniors to agree to their demand. So what we do is, even in our hospital, when patient comes for some checkups or for some questions, what we do is to involve their men through our own health staff members, explaining them the situation, what the mother or the pregnant lady is having, and what complications or consequences can be if we differ from this pathway. So then they are convinced, and they have the power to have a decision in the family that they will take women to the hospitals. Plus to that is at some points we notice that it is not only the non-availability of the service to the people who are making them differ from the pathway. It is also the attitude of the healthcare workers towards their problems and towards their social needs or social issues in house. So what strategy we have is that we try to see their issue from their point of view, and we agree to that they have problems convincing their seniors, family members who are in power of having a decision, and we see that they are not able to get easy transportation, maybe because vehicles are not available, or maybe because they don't have money. So added to that, what our strategy in Peshawar Women Hospital is that we even pay transport charges to the people who are coming to us from the target population. So it is a type of help to them to understand that it is important to see a hospital in this situation, and then they come back with, and we are having good response.
Is that fireworks?
Yes, it is.
Okay. Just checking.
Yes.
Yeah. I'll let you get back to your celebrations soon. Thank you very much for that. It was because I can imagine what the challenges, but really understand the explanation now. And because of the time, I actually want to, because mental health has been brought up a few times by different speakers, and there's a question related to that for Katsube-san. It says here, it says, I have a question to Katsube-san. Why is the suicide rate of Japanese women higher than in the other countries? Why is COVID-19 given a bigger impact on Japanese women compared to other countries? I guess that's related specifically to the suicide rate. If you could elaborate on that, please.
はい、ありがとうございます。これなかなか難しい問題で、私も今理解しているというか、用い得る情報というかを共有させていただくぐらいしかできないんですけれども、報告の中でもお伝えしましたけれども、日本以外の海外でも、この COVID、コロナ禍において自殺が増えるんじゃないかなというような懸念はありました。で、一般的に考えられる自殺のリスクっていうのは、このコロナ禍で社会的に阻害されているとか、距離を保つ人と会えない、でストレスが増す、でまたドメスティックバイオレンスが増えるですとか、経済的に困窮する、で学校閉鎖があって、悲観的になるとか、そうしたことから日本だけでなくて、自殺というものが増えるんじゃないかという懸念はされていたわけなんですね。ところが、結果的に、だから長期的に見たらまだわからないというふうには、言われていますけれども、これからの経過を見なければいけないけれども、社会的疎外感が増えるんじゃないかと言われた一方で、家族のつながりが強まったとか、経済的な支援策が取られた、そういうことで救済策が得られたからではないかというふうに、海外で自殺があまり増えなかったっていう理由とは言われているんですね。じゃあ一方、日本ではどうだったかっていうことなんですけれども、日本の、緊急事態宣言も発令されましたけれども、その時の状況を見ますと、ロックダウンというものはなかったわけですね、海外のような。で、他国と比較するとそれほど厳しくない状況であった。で生活に影響を与えるよう生活に重要な商業施設というのはクローズされなかったですし、そういう状況ではあったんですけれども、学校は3月の卒業式とか入学式という非常に3月から4月にかけて非常に1年の非常に重要な時期にクローズされてしまったという事態はありました。で一方で同様に経済的な困窮状態ですとか、メンタルヘルスの変化とかあったんですけれども、年齢別に見ますと18歳から39歳の 年代、40歳から64歳の年代、65歳以上の年代というふうに分けますと、より若い人たちの間にメンタルヘルスというか、うつの気分というものが強まったということ、それから経済状態もより若い世代に悪化していった。それから経済的な不安定によって死ぬことという自殺を考える傾向が強いのは若い世代だったという調査もあるようなんですね。じゃあなぜその日本の女性なのかということは、こういう状況を見てもなかなか難しいところはあるんですけれども、実は昨年の10月から11月にかけて、非常に自殺が多かった。じゃあその時何が起きたかと言いますと、日本のメディアで有名人、俳優がお二人自殺されたという事態が起きました。で、その時に非常に高くなったという状況が、データがあるんですね。で、だからメディアの報道によって非常にショックを受けて、自殺は伝染するといいますか、感染するということも言われていますから、そういう影響もあったというふうには言われています。ただ日本の場合、同様に他国と違うと言われているのが、女性が家庭の中で担わなければならない家事とか育児の時間や量が非常に大きいということですね。これは、日本のジェンダーギャップ指数が非常に低いということともつながるんですけれども、比較するとそこの違いはあると。メディアの報道、またその女性が、役割分担が非常に負担が多い、家庭での負担が多い、で同時にその家庭にいなければいけない、自粛とか、在宅勤務とか、あるいは仕事を失って家にいるようになって、さらにその負担が増えるとか、そういうことが重なったということも言えるかもしれないんですけども、じゃあ、本当にそれが理由だったのかというところまでの分析というのは私もよくわからないです。本当に正直なところ。ただ状況的にはそういう分析は調査の中でされているようですということはお伝えできることなのかなというふうに思います。
Thank you very much for the explanation. And I agree, it's not an easy one to answer, and I think we need to see and follow how and monitor this, in Japan, but also globally. And actually, just because of timing, I'm actually realized we're going to have to wrap up this session, and I'm supposed to try to summarize, but we have covered so many issues with a wide range of impacts on women and in children. It's a bit difficult to summarize it, but I think hopefully we've managed to at least start and touch on the discussions about potential solutions, how we can try to, as Kemi put it, step on the gas and move back forwards again and go forwards. I think what's quite clear is that we are all in this together, and the pandemic and its consequences, and this will both remain a challenge to humanity in the long while, and that's how it is. So sort of trying to summarize, I'm going to try to probably wrap up with some of the quotes that I kind of picked up along the evening from our speakers. I'm going to start with Katsube-san's quote, which really struck me actually. It says, when she said that global health is global health delivered by women and led by men. So around 70% of health workers are women, while 75% of health leaders are men. So I'm actually quite proud that actually in this session, without intention, it happens to be this way, that all of us representatives we're all women. And I hope that your words of the speakers will continue to inspire our participants and also future female leaders in global health. And when Dr. Ogundipe was presenting our advocacy that we've been doing in MSF, as she said, internally and externally, one of the sort of quotes I sort of read on an article she showed was that we cannot allow this pandemic to rob the next generation of their future. And as a pediatrician and as a mother, I cannot agree more. The well-being and long-term future of our current generation of children is just too important for leaders to neglect it, and we must not stop reminding them that. And as Dr. Azim explained, that as part of lockdown measures, sexual and reproductive health services were considered as non-essential. Well, this unfortunate fact, I think, has been experienced in many countries, and we must ensure that sidelining of sexual and reproductive health and rights, whether it's during a pandemic, whether it's in an emergency or in a conflict situation, should no longer be the norm. So on that note, I would finally like to thank all the organizers as well of this Congress for their relentless work to make this happen, despite all the necessary infection prevention measures. I just want to finish on the line that Katsube-san said about the shadow pandemic. And I think what we really want to ensure that we're bringing the women and children out of this shadow due to the pandemic and truly not leave anyone behind. So hereby, exactly as on time, I will be passing the closure of the Humanitarian Congress 2021 to the President of MSF Japan, Dr. Takashi Kurumiya.
皆様、長時間大変お疲れ様でした。2日間にわたり開催されました人道援助コングレス東京2021にご参加いただき、誠にありがとうございました。今年は昨年を上回る500人以上の方々にご参加いただき、各セッションでは参加者の皆さんからたくさんの質問を頂戴しました。そして、活発な議論を行うことができました。皆様のご協力、積極的なご参加に心より感謝申し上げます。それでは、今年の人道援助コングレス東京2021を簡単に振り返ってみたいと思います。オープニングセッションでは ICRC、MSF、それぞれの立場から、現在の人道援助で直面する課題についての発表があり、それを踏まえて、今回のコングレスの副題でもある、誰一人取り残さないための人道援助というものに、必要な視点を参加者の皆様からたくさんの質問を通して、より深く考えることができたように思います。シリアについてのセッションでは、ハムザ医師から当事者の視点からの見解、戦火アレッポでの活動の様子など、貴重なご発表、ご意見をいただくことができました。ICRC、MSF の発表からは、現在のシリアの人道援助の状況についての報告がなされ、これにより皆様の理解がますます深まり、新たな視野をご提供できたのではないかと思っております。気候変動と紛争のセッションでは、すでに弱い立場にいる人々が気候変動の影響によってさらに脆弱な環境に置かれていることを、さまざまな事例から具体的に説明いただきました。また、気候変動の問題は、レジリエンスや人間の安全保障にも大きく影響を及ぼしており、人道的な介入においても緊急的な対応と予防的な措置の両方の側面からバランスをとって活動していくことの重要性が指摘されました。多様なアクターが多角的にこの問題に取り組むことで、より包括的な対応が可能になると思われました。このトピックは日本ではまだまだ新しいものかと思いますけれども、各援助団体において取り組みがなされることを期待します。新型コロナウイルスが女性と子どもの健康に与える二次的影響のセッションについては、新型コロナウイルス感染症が妊娠可能な年齢の女性や子どもたちの健康にどのような影響を与えるかが話し合われました。新型コロナウイルス感染によって人々が安全な妊娠、出産のために必要なヘルスケアから切り離されている状況であったり、ロックダウン、貧困化などに伴って、女性や子どもが家庭内で暴力を受ける頻度など、そういったものが増加することなど、さまざまな問題と関連していることが分かりました。また、小児においては、従来の感染症治療やワクチンなど、基本的なケアへのアクセスが難しくなることで、実際に死亡率の増加につながっているという報告もあり、こうした問題に積極的に対応していく必要性が示唆されました。昨年から始まりましたこの人道援助コングレスでは、少しでも日本の皆さんに人道援助の現状を知っていただき、日本での運動に変えていこうということで、今まさに昨年のコングレスで議論された新型コロナウイルスのワクチン政策に関する議論が国内外で高まっております。 今年のコングレスは人道援助の未来、真に誰一人取り残さないためにをテーマに実施いたしました。誰一人取り残さないためには、紛争地で暮らす人々、移民、難民、国内避難民といった人々を含め、当事者の声を知り、その声に関心を持ち続けることが何よりも重要だと考えます。国境なき医師団は困難に直面する当事者の声を世界に向けて発信するとともに、人道援助の形で誰一人取り残すことなく、人々が尊厳を持って生きていくことができるよう、これからも活動を行ってまいりたいと思います。今年のコングレスは、赤十字国際委員会との共催によって、より多様なトピックを取り上げ、さまざまな分野の専門家をパネリストとしてお招きすることができました。開催にご協力くださったすべての方々に感謝申し上げます。また、来年以降も継続して人道援助コングレスを開催していく所存ですので、ぜひ Zoom 退出時に表示されますアンケートにご協力いただければ幸いです。それではまた来年の人道援助コングレスでお会いできることを楽しみにしております。2日間にわたりご参加いただき大変ありがとうございました。それでは失礼いたします。